nodules in the lungs, and they're asking about what should you do next, thing like that, you know. Next, amyloidosis. Well, this is another area that not commonly seen in the practice and the real life, you know, but I don't know. The questions always love to ask this kind of rare disease, you know. They show the picture, and mostly in the amyloidosis, they're showing the picture that coming in the biopsy or something like that, that they will see the homogeneous eosinophilic materials, you know, in the conglomerate staining, and the biopsy usually taken from the rectal or subcutaneous fat, you know. Renal and endo myocardial biopsies can be seen, but not the common, you know, and they separated into the primary amyloidosis that usually is another thing is a association with the multiple myeloma. Secondary amyloidosis usually is may associated with the chronic, you know, inflammatory disease such as rheumatoid arthritis and ankylosing spondylitis. Another point that I didn't mention here that can be asked in the question is about the familial Mediterranean fever. You know, FMF is a familial Mediterranean fever, usually presented in pediatric patients in the child coming with periodic fever. They present with periodic fevers, which means they had a fever for some certain period of times, and then the fever will subside and gone and come back again. When the fever subsides, the patient will looking normal, but when they have a fever, they may present with high fever and lymphadenopathies, you know, and hepatosplenomegaly. And usually those familial Mediterranean fevers, you know, later on would develop amyloidosis. The question may asking about the treatment. What would be the treatment that might prevent amyloidosis in the FMF? The answer would be colchicine. Okay, only the drugs that help in the FMF is the colchicines that will prevent secondary amyloidosis. In amyloidosis arthropathies, you know, usually is picture will present similar to rheumatoid arthritis. It can involve in the small joint, you know, in polyarticular involvement and symmetrical joint involvement, and the biopsy you will see the different, you know, and you see that amyloid protein deposit in the joint. Chronic infections such as like TB, leprosy, you know, those are another causes of the secondary amyloidosis. This area is crystal-induced arthritis. Okay, commonly is a gout. It's very common and always show up in the test as well. Gout, you know, is the conditions caused by the hyperuricemia, but not all the hyperuricemia will develop gout. Remember that. It's because of hyperuricemia and developed crystallized that called monosodium urate crystal that can be seen under the microscope, and it's metabolic disorder presented by the acute, you know, inflammatory, you know, response from the tissue depositions of the crystals. And once you see that is initiate the PMN response and causing the inflammations, and usually there's respond to the new crystals, not the old ones that you will see in the fluid. And it can present with different features. The common one is acute arthritis, acute gouty arthritis that called the podagra, that is affecting at the first MTP joint. They're coming with the sudden onset overnight, wake up with the pain in the foot, and found the swelling in the first MTP joint, cannot walk, that is a clue for diagnosis of the acute gouty arthritis. But definitely, diagnosis has to be based upon the joint fluid, the synovial fluid, that you have to demonstrate the crystals in the fluid. Another pattern is we call the intercritical gout. That is between the acute attack is subsides, and usually we're not going to be able to see in this group the people because they don't come to see you because they don't have any symptoms. They're coming, another pattern is tophagus, that is from developing of tophi, and that can be seen easily in the foot, in the earlobes, that you have to looking in that area. The factors that might aggravate acute attack, trauma, surgery, that is common asking when the people's coming for the surgery and later on they develop fevers, and then what you should do, after that, and then they might mention something about the pain in the foot, and you have to think could be an acute attack from gout. Alcohol and starvations, drug and high purine food that might aggravate acute attack. The key point is about the history of the podagras. That is a point to making diagnosis of the acute attack. And usually it will present with the symptoms of acute onset and episodic spontaneous resolutions. And or another group is you found that tophi and the crystals in the fluid, the joint fluid. Serum uric acid is not, is not not the sensitive or specific to the diagnosis of the gout at all, because it can be changed either high or low, especially in acute attack. When the people have acute attack of the gout, sometimes they usually have a low serum uric acid than the normal. This is because of acute phase reactants acting on the interleukins, and that caused by the uricosuric effect to the kidney. Uric acid in the blood may be lower than normal. Usually you have to do the test later on after they get over from the acute attack. The treatment, in the acute attack, you're using the NSAID, colchicine, steroid, that is key. This question can asking about, some people may have contraindication to using one of these medications, such as like, GI problems, with the GI bleedings, that you have to avoid the NSAID, may using the steroid rather than the other group of the medications, The other thing is uricase, that is a new drugs that just coming up and using in the case of to prevent the acute attack in the people who underwent for the chemotherapy of the cancer, the stuff like that, which normally we're not gonna see that here. For uric acid lowering agents, commonly used is allopurinol, which is oxytocin oxidate inhibitors, and the probenesis with the uricosuric and sulfine pyrazoles. Those are uricosuric agents that try to excreting the uric acid to the kidney. Benzbromarone, that is a medication that commonly used in Europe, not in the States. So basically, I don't think they were asking this question. So for the fibrostat, that is a new drug that is coming up in the market last couple years. I'm not sure whether they're going to ask the question, but sooner or later it may come up in that, because it's a new drug that acting as like allopurinol, but much more effective than the allopurinol. Then it may be coming up later. Pseudo-gout. Well, pseudo-gout is, maybe act like gout. They presented like acute gouty arthritis, the infecting in the monoarticular arthritis, but caused by different crystals. The only way that you prove that is going to be by a arthrosynesis and get the fluid, and looking under the microscope, you'll see the different kind of crystals in there and caused by the calcium pyrophosphate. However, you may looking at the surrogate evidence, such as like the chondrocalcinosis in the X-rays that can be seen in the wrist, or in the pelvic area, that you might, or in the knee, you will see the chondrocalcinosis. That may be another clue that help us to think the patient may have the pseudo-gout, the CPPD disease. However, you have to looking at the other cause of these crystals. They're asking about what should you do next. You have to be screening about the parathyroid hormone, hemochromatosis, and the hypomagnesemia. Hemochromatosis, I don't know whether anyone reviewed that or not, but usually they're asking the question about this too, because it's commonly seen in the state. The people may affecting by the iron overload, into cause the skin, which is rare. At the late stage, commonly is maybe affecting the liver, cause the hepatitis, diabetes because iron deposit in the pancreas, testicular failure, skin that maybe dark skinned, that is area that you need to looking, maybe review that before go to the test, because it's associated with some underlying, some genetic abnormalities that over-absorption of the iron. That always coming up in the question that what should you do to excluding or to do the small specific test, to diagnose of the hemochromatosis. Hydroxyapatites, that is rare disease affecting the elderly, but it's always asking in the test, because like a lot of the elderly peoples in the state, and this is a disease that commonly seen that it causes the arthritis mainly in the shoulders, that called the Milwaukee shoulder syndrome. Some people call Milwaukee joint syndrome, that affect as a destructive arthritis from the crystals. That crystal is apatite crystal, and you cannot see that crystal at all, because it's very, very small one. And under the microscopes, you will not see that. Only the electron microscopes that you can demonstrate the crystal, but you can see by another ways using the staining that called alizarin red staining, that you will see it's become a red patch in the fluid. And it will present with the calcified tendinitis and the bursitis. The X-ray will showing that they have a calcified in the shoulder of surrounding the shoulder with in the tendon or the bursa, and some people will show up with the pain in the shoulder, unable to move or difficulties to using the hands, you know, and sometimes they show in the picture that you will see the swollen in the shoulder. In the front of the shoulder, you will see the bursa, you know, there's a lot of fluid there. And basically, it's a cold, it's not good, it's a, this fluid, this bursitis or this tendinitis, it will not inflame as much as the other thing. Usually when you touch it, it will not warm, you know, but it's some fluid there, you know, and that is a point, you know, you will see that it's a swollen, but not see that much upside inflammation, not see that much redness or warm to touch, you know, and they rarely poorly respond to the NSAID, you know, they usually end up with the steroid injection. And because of the synovial fluid, you know, release a lot of stuff, you know, the collagenase and proteinase, that's why it has a lot of extensively damage in the joint and polyarticular joint structure, you know, and like I said, that it's a large, cool effusions, you know, they have a lot of swelling there, you know, but not much of the side inflammation. And sometimes you can see it's a bloody fluid, you know, because it's bleeding inside. Now, wake up. Okay, now it's time for you to answer these questions. I hope everyone will get the right answer if you're listening from what I talk. If you get the wrong answer, I know you're sleeping. So you may have to go back and review it again. ขอ power vote ได้ไหมครับ Okay, now this question is a 19-year-old African Americans, you know, walk into the clinic complaining the weakness, malaise, and progressively worse over the past month. And she lost about 9 kilos, okay, and you know, has some symptoms of the arthralgias, abdominal pain, you know, some kind of like rashes, you know, and the vital signs has a fever. The temperature is 40, but pressure is okay, pulse 76. The question is, which is the following pair of the antibodies would be more specific to this patient? What is the disease the patient has, right? So you think about the SLE, like I said, you know, because they usually present with wake symptoms, you know, with the weight loss, you know, with the progressive weakness, you know, arthralgia, rashes, you know, they didn't show any tests on that. So they're asking specific for antibody. So we know that something had to be do with this antibody, you know, so you think this is SLE. So what would you expecting in the choice? So if you're looking at that, then you don't have to go to many choice, right? So you know what you should looking for. So it would be B boy, right? It should be the double stand-in and anti-SM Smith. That would be more specific, the highly specific test for the SLE. So, right, is B. Oh, did I ask you to vote yet? Oh, I already passed that. Okay, now that is a test question. Okay, now the real question. It's coming, this is a grandma teacher, you know, who has a 2 weeks pregnancy and went to see her obstetricians. And she worried about the outbreak of the parvovirus B19 because she afraid that she might contact this, you know, and she afraid that the virus may be harm to her fetus, okay? So the doctor informed her that there is a less than 5% chance that what's gonna happen. A, chorioretinitis. B, the hydrophysalis, C, Regalis, and D, microencephaly. E, Hutchinson teeth. Sorry, this misspelled it. Okay, vote now. Okay, well, it's spreading out between A and D. Because C, I don't know what is that. What the hell is that? I don't know. It's something that nobody knows what is that, you know. So the answer should be something that we understand and knowing. So turned out to be just only 9% got it right. It's just only B, the hydrophysalis, you know. Chorioretinitis, microencephalopathies, Hutchinson teeth is a congenital syphilis. It is a congenital syphilis, okay? There's a spirochete, but it's not causing congenital syphilis, okay? So basically, it's a hydrophysalis. That. All right, go to the next one. 21-year-old man coming with morning back pain for 3 months and improved after day progressed and when exercise as well. Physical examinations show that revealed that he has a diminished anterior flexions of the lumbar spine and a muscle spasm in the lower back and forward stooping when he walks. So the X-ray showing the bilateral, you know, sclerotic change in the SI joint. So what is the diagnosis now after reading this? It's a spondyloarthropathy, it's AS, right? So which of the following tests you would like to do to provide it the most useful information? A, ESR. B, rheumatoid factors. C, serum uric acid. D, ANA. And E, HLA-B27. Vote now, please. Oh, wow. Oh, 83% answer is E. So the less about 17% maybe the answer B. Is this because you want to excluding that? Or you just want to make sure that this is spondyloarthropathy? You know, because they call the seronegative spondyloarthropathy. Sometimes they call the SNSA, which means the seronegative, which means the rheumatoid factor negative. Okay, so that is an old term they're using, seronegative spondyloarthropathies, because normally serology for rheumatoid factor should be negative. So some people do the rheumatoid factor test just to excluding that, which I don't think we really doubt in this case that they have the spondyloarthropathy, right? I don't know. So I think basically 83% of people got it right. The most useful then mean that it should help us to understanding. So the HLA-27 is really helpful to think this is associated with the HLA-27. Okay, move to the next. Now come to the children. 8-year-old child, you know, presented with the low-grade fevers, arthritis, colicky pain, purpura. Again, purpura. Oh gosh, get to the answer, right? They have the stool-quack test positive, had the red cell cast in the urine, has a proteinuria, and normal platelet count. So what is the most likely diagnosis? I don't think you need to looking at the choice. You can go ahead and making a mark. All right, A, SLE. B, Rocky Mountain. C, idiopathic thrombocytopenic purpura, D, hematuria purpura, and E, post-strep glomerulonephritis. Okay, vote now. Oh my goodness. 91% got it right. I think about 10% probably sleep through these 2 hours now. Actually, probably 4 hours because including Dr. Alisa's session, 2 hours too. So, or maybe come here late. I don't know what is the reason that, but okay, we accept that. They might think something different from what the normal people think. I don't know. They might expressing idea later or they might asking me question later. So, okay. All right. Mostly got it right, 91%, it's hematuria. So I hope you will not miss the question like this again in the test. You will got the easy answer and easy score on that. Now come to the other one. 55-year-old woman brought to the emergency room with a fracture of the femur. She well dressed, no sign of trauma. So they're asking, what is the following test is most likely the cause, what is the following is the most likely the cause of her fracture? After read all these questions, I think many people just don't really know, have no idea what's going on. So go on, move looking at the answer so you may have some idea what is the choice may help you to understand what the answer is going to be. A is chronic osteomyelitis. B is a trauma. C is a secondary infection from the open wound. And D is a primary bone disease or metastasis. Okay, vote now. All right. Why people think it's D? Okay. But surprisingly, they have 3% choose E, which is not presented at all. Wake up! Oh, come on! Hey, who is those who want the 3%? That's it probably about 1 or 2 people, right? I think they might just teasing me. I know. Okay. When you're looking at the question, you just have no idea because they didn't showing anything to make a clue what is that, right? There's a 55-year-old woman brought to emergency room with a fracture, no any trauma, no accidents, and she well dressed, so which means it's not any kind of disease that's malnourished that causing the fracture. So basically, now we have to go to looking at the choice and excluding one by one, right? A, the chronic osteomyelitis, probably less likely because she well dressed, doesn't have any fever, nothing at all. So B is a trauma, so it doesn't have any history of trauma at all. And C is infections, which is not any sign or any clue of that at all. So basically end up with the D, okay? Because we just exclude everything else. So this is just the one kind of question that sometimes when you see that, you just have no idea at all what's going on, what is this patient have, but you just go by excluding one by one and end up with the D, okay? And I think number E probably would be the one that exclude everything out and don't know what's going on, then we choose E. Okay. Next, 30-year-old female, non-smoker, has a bilateral puffiness and swelling in the finger and joint pain. So she has a cold exposures and stress cause branching or cyanosis of the fingers. She's not taking any medicines. What mechanism of this patient disease is most likely result of which of the following? So after read these questions, you know right away, right? What is that? What is that? Has cold exposure and showing some changing the skin. So that's only one thing. Okay, right out, phenomenon. So go on to the next, go to the answer. Okay, A is vasospasm and thickening of digital arteries. B is hyperviscosity of the immunoglobulin IgM antibodies. And C is immune complex vasculitis. D is a thrombosis. And E is a embolisms to digital finger. F, somebody choose F? Oh, no, not in there. Okay, go ahead, vote. Okay, well, I think 50% vote for A and about 30% voted for C, which is immune complex vasculitis. Okay, now we have to go back to look at the questions again. Basically, this lady is non-smoker, right? So it's no anything that to think that it could cause any vasospasm from the smoking. What smoking cause any disease? Can the smoker have anything more than the other people that involved in the blood vessels? Wake up, answer the questions. All right, okay. And then she has a puffiness and swollen and painful joint. And they mention about the cold exposures and the stress and the cyanosis of the fingers and no any anti-medication. So they're asking about mechanism, what is that? So if it is a vasculitis, okay, if it is vasculitis that affecting the causing the symptom that what the patient has, basically one thing that you should think is a skin rash. They should mention anything about skin rash. This is just changing of episodic, which means it comes and goes. Okay, it comes and goes, which is mean it's on and off. So it doesn't look like the skin rash that persisting all the time. So basically, I think this is look like Raynaud phenomenon, which answer should be A, because it's vasospasms. Okay, so if it immune complex vasculitis that causing vasculitis, basically you should see in the skin rash. You should mention anything about the rash and describing on that, you know. But hyperviscosity is one thing that can be presented like this too, because when you have the hyperviscosity, you know, when you expose to the cold, the blood will be very thick, and that causing a problem that in terms of you don't going to see like the Raynaud phenomenon. But usually the hyperviscosity should coming with like, you know, after something's going on, such as like those smoker who has a severe myeloproliferative disorder, you know, has essential thrombocytosis, you know, or has some polycythemia vera, something like that causing hyperviscosity. But another thing is the immunoglobulin that can be very, very, very high in the blood that causes the very thickness of the blood. Okay, so I think the people who answer C, you know, should looking back and read the question again, you know. All right, go to the next one. 55-year-old man has a 10-year history of the ulnar deviations of both hands, a large joint, and has nodules down both forearms. In addition, he has an ulcer in his lower leg. The patient would also be expressed to have which of the following? A, high rheumatoid factor titer. B, monoclonal gammopathy on the serum proteins. C, driven insufficiencies. D, osteophyte at the marginal to the joint. And E, iron deficiency anemia. Please vote now. Okay, 68% got the answer A, and the laser that's spreading out between C and D. Okay. All right. Let's go back to the question again. So this question asking about men at the age of 55. They presented with the ulnar deviation in both hands. So something involved in the wrist that causing the damage in the joint, that mainly as a result that is imbalance of the muscles that pull the hand outward, that causing the ulnar deviation. All right. So something that involved in both sides of the hands, not the hand, in the wrist, that causing that. Okay. And they found the enlarged joint and nodules. So what is that? It's more likely that this is something that involved in the symmetrical joint. In the elderly man, like I said in the beginning, okay, is more likely this is rheumatoid arthritis in the elderly. If it's young adult, usually it's common in men, in women, you know, but this is men. So they have equal chance now to get rheumatoid arthritis. And also they has an ulcer in the leg, which is something literally is a clue that something affecting in the leg, that either the vascular insufficiency or something affecting the blood vessel itself, which is thinking about vasculitis. So this is a man who has ulcer, has a nodules, has something affecting bilateral symmetrical joint. So I believe it's more likely this is a rheumatoid. So what were you expecting? If the rheumatoid in the men, in the elderly, like I say, rheumatoid factor usually is not really helpful, but this disease is seems to be positive rheumatoid nodule and has some ulcer. So you have to think this is a severe disease. Then you would expecting that rheumatoid factor would be very, very high. So the answer would be A. Okay, would be very high rheumatoid factor. That what you're expecting. So for about the monoclonal gammopathy, you know, you can see in the case that may have the ulcers that you think that they may have some disease, but not like in this setting. Okay. All right. I think that's all I have for now. I hope you enjoy it, and I will be happy to entertain your questions, and may or may not get the answer. I don't know. Let's try.
Are there any questions for our speaker? Certainly there must be a question or two out there. All right, well, thank you very much, Doctor, and come back at 3 o'clock for our next speaker.